Okay, we have Dr. Shamanna, and we have time up to tea at 4:30 or so. Yeah, please. And we thought, I was told that we could have somebody else, but that's not possible. Please go ahead, please tell yourself, your subject and all that.
Thank you very much, sir. I'll keep to time, sir. And,
Yeah, please.
thank you very much. And I want to thank the organizers and especially Professor Sharma. I don't know why Professor Sharma opted to have me as one of the speakers, because I have two disclaimers to make. The two disclaimers are: I am a person who's been trained as a quantitative researcher, so I'm a medical person.
That's okay. we need the combination of quantitative and qualitative.
Yes. And the second disclaimer is more important, sir, because I'm placed between all the doyens who have done phenomenal work, and I feel very puny in front of all of you all. So those are the two disclaimers I make, right? And what I'll try and do is I'll try and actually structure my presentation to fit the time allotted to me in terms of really looking at the profile of tribal population, and that's the reason I made this disclaimer. I said we need to present quantitative information before qualitative information can be complementary to whatever it is. And I'll give you an overview of just a few public health challenges, because we've been talking about all these challenges, and we have a framework to address policy issues related to these public health challenges which is available to us. So how do we fit whatever we do within the framework, or how do we look at this framework and think? And again, I want to present some selected case studies, and you will excuse me again for this, because all my case studies come from medical personnel setting up tribal health initiatives. So I'll repeat it once more. These are doctors who are setting up tribal health initiatives. So that is another disclaimer I would like to make. If it provokes people, let it be. So given that, I've tried to think, and I've made a suggestion in terms of the way forward. Very quickly, all this has already been sort of discussed in terms of forming a proportion of population which is about 8.6% as per our census. Incidentally, if you look at the decadal growth rate, that's been pretty decent amongst the tribal population as compared to the general population, right? So it's good. And one other thing probably which needs to be highlighted is the fact that the sex ratio among the tribals is much better compared to the general population. So probably it also speaks about some of the tribal areas, basically having a matriarchal sort of a society, and hence you will see the green parts and then the orange parts, etc., which are the places which predominantly have the distribution of what we call as the scheduled tribe, numbering about 705. This is just to give you a snapshot in terms of at least the tribal populations in this country make up close to 2 states put together, about 110 million population out of the total 1.25 billion population. These are the different places as per the census where the tribal populations are. I just want to go further to tell you, if you look at some of the indicators, and especially socioeconomic and social determinants with respect to the tribal population, education, literacy, etc., compared to all social groups and the scheduled caste, the tribal populations haven't done as well as the scheduled castes and the other castes. I think that is something which needs to be kept in mind with respect to looking at literacy per se. Same thing with enrollment rates of scheduled tribe students into different levels of education, whether it is primary, upper primary, and secondary. They're pretty more or less, it's been increasing, but the increase has been much less compared to other social classes as well as the, compared to within the tribal populations. Yeah, this is where I would come on to trying to give you a snapshot about what the overall health status and especially the health status of tribal populations are. And I've indicated here the areas which are sort of circled, encircled here, are with respect to, the different indicators like child mortality, under 5 mortality, antenatal care checkup, percentage of institutional deliveries, childhood vaccination, etc., full immunization. And I think my previous speaker, also my senior from the university, I belong to the same university, Karnataka University. I also worked in regional health, training center in Kalgadgi, which is part of the tribes he was talking about, and we had quite a few of them. So I should tell you, sir, I think after, exposure to, these communities, that's when we really understood what we practice as medicine is. And thank you very much for enlightening us. And I think it falls within the purview of, even though the institutional deliveries are low, even though the childhood vaccination is not, there are reasons why, the reasons which you highlighted with respect to this. And I think I will see it with a pinch of salt. If not a pinch of salt, a kilo of salt. Right? Again, this is about the National Family Health Survey and the most recent estimates, 2015 and 16, which points to, the immunization status and paid pretty much, again, 50% of what is expected or less than 50%. And unless until we find the reasons of why, I think revisiting the policies would become a futile exercise. And that is where I think the complementary role of having all of you helping framing these policies would be more important than somebody sitting in Nirman Bhavan and doing it. So I think that is what I would like to highlight from this. Same thing with respect to insurance coverage and accessibility to healthcare. Very negligible in terms of thing. You look at, the responses with respect to access, that is physical access, with response to availability of medicines, with responsibility of at least one problem in accessing healthcare. These are what has been documented and these are what has been published, which gives you a picture in terms of saying that we have done well, but when I say we have done fair, but we need to do much better in terms of looking at our policies and programs. Yeah, I'm not going to go into more health problems, but to just tell you that I think we are sitting on sort of, I should say, a trimodal sort of a distribution or a transitional phase where we have the unfinished agenda of communicable diseases and infectious diseases and the emerging problem of non-communicable diseases, and along with that road traffic accidents, injuries, etc., which you see also in this tribal populations as well. So if we need to frame policies, if we need to look at this much closely, I think we need to look at all the three of them. Finish the agenda of communicable diseases, start looking at it more deeply with respect to non-communicable diseases, and this is what the picture is. Although it may be low compared to other things, but diabetes, asthma, thyroid problems, endocrine problems, whether it's women or men, are also increasing. If you want to call it a biased estimate in terms of saying that it is what is reported by people, it also means that there is information about these conditions which people are trying to report, which is also something which we need to look at very closely when we are making policies. So that's another thing which I would like to highlight here. I think the speakers have highlighted the risk factors with respect to non-communicable diseases, and especially tobacco use being highest among the scheduled tribe population as compared to other classes. Consumption of alcohol increasing, both genders. Early marriage, both men and women, and early childbirth is also, it's quite high. And it's been estimated that at least 2/3 of the people have a demand for family planning, and 1/4 of them is still to be not, unfulfilled in terms of the met need. The HIV prevalence rate among the scheduled tribe population is as the country's average with respect to the percentage. And I think the speakers highlighted about malnutrition and anemia. That's again still a continuing problem, and we need to find out, in addition to all the other social determinants, the why factor in terms of whether there is something which is inherent. And this is where I think even basic researchers would come into picture. And we know the issues with respect to doing basic research in vulnerable populations like the tribals. We had difficulties when I was with my parent institution in Andamans and Nicobars, whether to go with the Jarawas, the Onges or Sentinelese, etc., the tribes which are prevalent there and which are, protected tribes in those countries. So where do we go from here? This is something which has originated not very long ago. It's about 8 years or 9 years ago. This is called as the health systems approach. Right? The health systems approach looks at certain system building blocks which are highlighted here, where if you put yourself with respect to tribal health and provision of services to the tribal populations, we have to look at initiatives of service delivery. The one size fits all doesn't work. We need to evolve contextually relevant policies within a broader framework of what we are doing. So next thing is about the health workforce or human resources for health. Information. When we talk about information, it's not only information about availability and accessibility, it's also information about affordability and information about behavioral change with respect to changing people's behavior. Technologies and medical products. Financing, which is a very big issue with respect to how do we finance services. Yes, we may have an outlay, we may have the budgets committed, etc., etc. How much of it actually gets spent? But how much of it actually gets spent in providing services rather than administering the services, which is a common problem which we see within most of our service delivery initiatives. And last but not the least, I think the issue which needs to be highlighted and more is the leadership and governance issues. The reason I'm saying this is all the models or all the sort of case studies which I'll present in a few slides from now are all driven by passion, driven by individuals, driven by certain, very strong, if you want to call them headed people, etc. But they have done it. Unless until we have that kind of a passion and that kind of a drive, I think it's very difficult for us to actually push this agenda, and it may be a very important part of policy making, but it's an extremely important part of policy making, the leadership and governance. So if we can actually put all of these together, we can improve access, we can look at coverage, we can look at safety and quality so that we can get all our outcomes with respect to what we are thinking of. So the next 5 minutes I'll spend talking to you about the different models which I am aware of. Let me here again say that these are some of the selected models. I have not looked at AP and Telangana because I know that there have been, administrators and there have been people who have implemented some of these models. This is a very interesting model set up by Drs. Reggie and Lalita George in a place called as Dharmapuri district in Tamil Nadu, in a place called as Sitilingi. And basically, if you look at it, it is holistic health in terms of really looking at healthcare, community health, farming, and craft work all involved. It's placing people's health in people's hands, and that is what they have done. And they've been very successful since the last 25 years with respect to the work which they have started. And this is what they seek to do: highest possible physical, mental, social health, enhance the socio-economic status. Mind you, these are all these are only to the tribal communities within that areas, and where pride, self-respect and self-reliance with active participations in programs meant for their welfare. Meaning the whole program is run by a couple of doctors who are outside the system. Everything else is run by people drawn from that tribal community, and that is what it is. This is one example of a very interesting tribal health initiatives. I think what we need to do is to look at all these experiences and take the best practices to drive our policies. Everybody knows about Dr. Sudarshan and Karuna Trust. Started off in BR Hills areas or MM Hills areas, the Veerappan area, earlier the Veerappan area, etc., where Dr. Sudarshan himself was involved very much within setting up what is called as the Vivekananda Girijana Kalyana Kendra, the part of the ITDA, and started with leprosy work, and over a period of time expanded to look at other areas of health, education, livelihoods and advocacy. Today probably they have, last heard they were probably the biggest suppliers of honey to Himalaya or to other, Dabur, etc., because they were working with this, and honey was something which they were, accumulating, and they were supplying it to all these big companies which make the biggest thing, medicinal plants for that matter. And that is something which has been done successfully here, and Karuna Trust has expanded to Orissa, it has expanded to almost Arunachal Pradesh, Northeast, etc. The problem with Karuna Trust is everybody wants them to take over and run the 24/7, etc. PHCs. The problem is what Karuna Trust can do afterwards. Governments are not ready to take it back once they give it. So that is an issue with respect to running a very successful program. We have to keep it at the back of our minds. The other very interesting example, I'm not biased because I belong to Karnataka, but I'm just trying to share, some experiences with respect to thing. This is an interesting experience set up by Dr. Balasubramaniam. He's my contemporary from Mysore Medical Colleges. These people in their internship, 7 or 8 of them in their internship, went and set up, a tribal facility in a place very close to the Nagarhole, and Kabini Reservoir area. And they worked in concrete pipes, the drainage pipes which were there, in the concrete pipes. The first hospital started in a drainage pipe, literally. And what they did was they went around the hospital collecting physician samples and used to go and distribute things. And when they lived with these communities, that's when they really understood the strength as well as the issues related to the communities, and that made them get into a broader area, and they've expanded themselves. Now it started somewhere in 87, 88. Now you have health, education, community development and training sectors, and also they have a leadership institute in Mysore. In addition to having a leadership institute in Mysore, one of the first courses which has what is called as Masters in Development Studies. They have people who train managers and who train specialists, and these specialists are people who can run programs, and especially programs, they have a very successful Masters in Development Studies, and a ready batch of 20-25 people are available for placements for different projects, and especially tribal projects, because these are all people picked up from the local communities, because they have their open school system. Education or Viveka is what they tried. Education, those children have now become graduates. Those graduates are brought into master's program. It's a sort of rotation system in terms of what they have done, and it's been very successful. Sir, the chairperson, already talked about Society for Education, Action and Research in Community Health, which the couple, Dr. Abhay and Dr. Rani Bang, which has now also been taken over by their progeny Anand, which is in Gadichroli, which is, Gadichroli is, it is just on top of our Adilabad district, and at the same time it is, infested with Naxalism, and it's a very big, communities of tribal population. I think the contribution of Dr. Bang and the family probably has to be written in golden words, because they were probably the ones who wrote one of the most fascinating papers on tribal health in the Lancet as early as 1995. And this was based on home-based newborn care and home-based institutional deliveries, home-based deliveries rather than institutional deliveries, because that was the need which the communities, just like the Kumbhi community, which Sir spoke, where people preferred to have care at their homes as well as deliver at their homes by the elders within the community. And this one has now become a very successful experience, which has spread to places like Rajasthan, most of Madhya Pradesh, Jharkhand, etc., where they have the home-based neonatal care approach. And from moving from family planning to what is now called as women's reproductive health, we don't anymore call it family planning, we call it reproductive child health or reproductive health. That's been a predominant contribution to the global community by the experience of what has been done in Society for Education, Action, Research and Community Health.
Abhay was a member of KAKA committee. That is why you find this alcoholic restrictor and all that.
Precisely, sir. And that is something which has also been highlighted in this thing. This is again another interesting experience. Prakash Amte, the son of Dr. Prakash Amte, son of Baba Amte, again the Gandhian, etc., who set up this place called as Lok Biradari Prakalp in Maharashtra. Looking at, it's basically a people's brotherhood project working with Gond tribals. hospital, a residential school, and an orphanage for injured wild animals. A couple of days back, I shared a WhatsApp message with some of the students and other groups in order to look at wild animals which Prakash Amte himself has within his vicinity. And this is something which they are able to do and sustain in a place called Hemalkasa, where 40,000 individuals annually and about 600 students go to the schools, the health center and schools. This is another interesting sort of a model in Maharashtra. Other case studies, Mahan Trust, Ashish Satav, Melghat, Amravati again in Maharashtra. Although not predominantly tribal, I think the whole experience of setting up primary health centers, the credit goes to the Aroles in Ahmednagar, in Jamkhed, where they set up the Comprehensive Rural Health Services project in Ahmednagar. And I think that is something which I want to highlight. And I wouldn't, I think I should also make a mention of the newer generation, the Generation X when it comes to healthcare. And this is a group from the All India Institute of Medical Sciences in Delhi who actually went and set up this place in Bilaspur, in a place called as Ganiyari, which is called as Jan Swasthya Sahyog. They left very lucrative faculty positions and big positions like associate professors, assistant professors, professors of pediatrics, etc. of All India Institute, went and set up this place in Ganiyari basically to serve the communities of the mining areas as well as the tribal communities in and around Bilaspur. And of course, again, Dr. Ravindra and Smita Khole in Melghat and Maharashtra as well. So what I have done so far is I have tried to share with you all the models with respect to tribal health for us to really look at, doing a meta-analysis or doing a sort of systematic review of these models and try and get the best practices to inform our policy making with respect to research and advocacy. Of course, nothing can happen if these rights and guarantees, the enablers, are not actually implemented. We may have a right, we may have a law, etc., but the law will only make sense if it is implemented. So all these enablers needs to be taken into thing. Dr. Chakma is here, he will speak about Jabalpur, so I won't eat into his time. But I want to highlight the fact that there's this Tribal Health Research Forum, which was set up in 2010, I understand, and you meet 3 to 4 times in a year to take stock of what is happening in the field of thing. I think we need such kind of pressure groups in universities, we need such kind of pressure groups in governments, think tanks, policy making, bodies, etc., to really look at stock taking of what exactly is happening and how we can go forward. If you want to achieve universal health coverage, I probably think that universality, equity, which are the guiding principles, non-exclusion, non-discrimination, comprehensive care which is rational. When I say rational, pluralism also comes into picture, and I've been involved in evaluating one of the non-communicable diseases program both in South Africa as well as in parts of Uttar Pradesh. In Uttar Pradesh, yoga is a non-negotiable for a non-communicable. You can opt for Ayurveda, you can opt for allopathy, you can think, but you can't. Yoga is a must. That has been mandatory, which means to say if somebody drives it, it gets driven. If somebody doesn't drive it, it will not happen. So the thing is about financial protection, rights I talked about, accountability and transparency. Not to forget, whatever we do, it's very nice standing here, air-conditioned rooms with all, big facilities, talking about people who should be involved in doing or helping us make policies. I'm sorry about my last parting comment, but that is what it is. We can stand here and talk about tribal health and every policies, etc. But where are the tribal people? Thank you very much.
May I ask just one simple question? All these examples.
We'll take that afterwards,
Afterwards? Okay.
Yeah.
By when one is going to.
No. We still have one. What we can have only after discussions. Well, thank you, doctor, because you have given the names with which I have been very, very intimately connected. Baba Amte was the chairman of Gandhi Memorial Foundation. I was the member secretary. Abhay Banks, I was the first consultant for Abhay Bang at Search. And all this, the Maharashtra people at least. Yeah, these are all. And Dr. Arole, we had a joint project with Dr. Arole recently from the tribal department on this malnutrition. As I said, mega project of 10 crores. But we as anthropologists, I mean, because this is, there are so many, we as anthropologists have to take these as research areas and take these case studies as our research case studies, not coming from the health side, but we have to look at it from our side also, as to why they have been successful and what kind of message did you give and how they are, they have been addressing the concerns of the people, and how these doctors, they had to go to the people. Many of them, they started all with curative work. From curative, they had to go to the preventive, and from preventive, they had to go to the development. So this march that they have taken, and then they have come to this primary healthcare approach and all that. This is something which we have to understand as a research exercise and should go into our curriculum. That is what is necessary. I mean, apart from the policy, that is one aspect of it. And because there are a large number of students here, that is the other aspect of it.